Bismillahirrahmanirrahim. It gives me pleasure today to hold the presentation for the 6th-year medical students, and my topic today will be about the urolithiasis. Urolithiasis is defined as an aggregation of crystalloid material or materials which are then excreted in urine. Internationally, the urolithiasis or urinary tract stones is the third common urological disease after urinary tract infection and prostatic disease. The calculus formation can occur at any level of the urinary collecting system, as we see here. If it's formed in the kidney, it is known as nephrolithiasis. If it is formed in the ureter, it is known as urethrolythiasis, or if it's formed in the bladder, it is known as cystolithiasis. Regarding the risk factor and the etiology for stone formation, the imbalance in the pH value of urine is considered as one of the most important risk factors for stone formation. Some stones, such as uric acid stone, cystine stone, oxalate stone, tends to be formed in acidic urine. However, other types, such as phosphate stone, tend to be formed in alkaline medium, which is due to urinary tract infection by a specific type of microorganism, which tends to change the pH value of urine from acidic to alkaline medium. Renal infection also predisposes to alkalization of the urine, which also favors stone formation. Hyperparathyroidism results in excess production of calcium inside the body, which is beyond the excretory capacity of the kidney, which tends to form stone due to deposition of the calcium inside the renal tissue. Metabolic disorders such as hypercalciuria, hyperphosphaturia, oxaluria, and uric acid stone also predispose to stone formation. Dehydration for people or population who are living in hot areas or districts with minimal fluid intake result in supersaturation of the urine with stone crystals and predispose to stone formation. Stages which may be either acquired or congenital with an obstruction of the urine flow, which encourages the salt precipitation. And also, as we see here, the immobility, sedentary life, dehydration, metabolic disorders, all of these factors are risk factors and predispose to stone formation. There are different types of renal stones or urinary tract stones. The most common type is calcium oxalate stone. It represents about 80% of all types of stone. Calcium phosphate stone, strovite stone, triple stone, which are mainly one of the most important type of infection stone. Uric acid stone and cystine stone, which tends to be formed in highly acidic urine. Regarding the pathological effect or change which occurs in the urinary tract as a result of stones, it may cause either obstruction, urinary tract infection, urethral irritation, or it may reoccur after spontaneous passage or treatment. The obstruction may occur in the upper or lower urinary tract for shorter duration of time when it is acute, or longer duration of time in case of chronic obstruction. Urinary tract infection, the stone itself is a foreign body, or as a result of obstruction causing stasis and supersaturation of crystals or microorganisms which predispose to the urinary tract infection. Urethral irritation in case of acute attack, it causes hematuria. In case of chronic conditions, it causes change in the epithelial lining causing squamous metaplasia, which may predispose to malignancy later on. And as I said, the stone may reoccur after spontaneous passage or treatment. These are the presentation of the patient with stones. Either he is presented with nausea and vomiting in case of renal colic due to what is known as the renointestinal reflex, or pain in the groin, which is referred to the lower abdomen or the groin region. Dysuria, frequency and urgency if the stone is approaching the lower end of the ureter, or signs such as fever, dehydration, tachycardia in case of urinary tract infection such as pyelonephritis, renal angle tenderness, and hematuria in case of passing of the stone, which causes scratching of the urethral mucosa and the patient is presented with hematuria. Concerning the clinical manifestation, the stone may be accidentally discovered. This is known as a silent stone if the stone is lower calcial, causing no obstruction of the urinary tract. But as the stone moves and causing obstruction, it may be manifested with colicky pain, which starts here in the renal angle as a sudden attack of colicky pain, and it may be radiated or referred to the lower abdomen and the groin and upper part of scrotum in case of male, or in case of female it refers to the labium. This is the site of radiation of the pain due to obstruction. And also it may be presented with a dull aching pain in case of long-standing obstruction in chronic condition, sometimes also frequent or painful maturation if the stone is approaching the distal part of the ureter or the intramural part due to irritation of the trigone, which is most sensitive structure of the urinary tract. The urine may be cloudy or fully smell in case of urinary tract infection. Also, the patient may be presented with nausea and vomiting due to renal-intestinal reflex, fever and dry jaws in case of infections such as pyelonephritis, gross hematuria due to injury of the mucosal lining of the urinary tract due to passage of stones. Manifestation of complications may be either acute or chronic. In case of acute, severe colic pain referring to genitalia, nausea, vomiting, microscopic or macroscopic hematuria. In case of chronic stone disease, it may be associated with renal function and manifestation of uremia such as anemia, weight loss, loss of appetite, especially in case of bilateral renal stones or stones in a solitary kidney. Concomitant infection such as fever due to pyelonephritis, infected hydronephrosis or pyelonephrosis, acute urinary retention if the stone passes until it reaches the bladder neck or the urethra, renal swelling with advanced hydronephrosis due to long-standing obstruction. After the stone is being formed, it may either remain at the site of original formation, in this case it's known as dormant stone, and as I said, if it is in the lower calyx without any obstruction, it may remain as a silent stone, or it may increase in size with passage of time. The stone, if it's small enough, it may be migrated along the urinary tract, and finally it will be expelled outside the body if the size of the stone is less than 5 millimeters, or it may be impacted at one with a normal site of impaction due to narrowing of the lumen of the ureter such as the pelviuteric junction, at the middle third of the ureter due to crossing of the ureter over the iliac vessels, at the juxtavesical part, which is the site at which the ureter enters the bladder, or in the intramural part or the ureteric orifice. When we start investigation for stones, our aim is not only stone diagnosis but also diagnosis of the cause of the stone formation. So, to detect the anatomical or functional obstruction, we do intravenous urography or CT urography, which is mostly used nowadays to detect causes of obstruction such as uretropelvic junction obstruction or urethral strictures which impair the urine outflow. Sonography for evaluation of the post-voiding residue, and urodynamic studies in case of bladder outlet obstruction or in case of neurogenic bladder. Urine analysis to diagnose infection or hematuria, and culture must be done in case of urinary tract infection. Metabolic evaluation, which includes urine analysis for determination of the urinary pH value and type of excreted crystals. 24-hour urine sample for evaluation of the daily urine output and concentration of stone-forming substances. The serum level of calcium, phosphorus, uric acid, and parathormone hormone, and stone analysis for any retrieved stone fragments. For diagnosis of stones, we start by proper history taking, asking the patient about dietary habits, medication, and family history of stones, because some stones, such as cystine stones, tend to be found in families with genetic predisposition. Ultrasonography, which is the bedside test and one of the safest investigations for diagnosis of stones, can be done safely in pregnant females and young children without any hazards of radiation exposure. As we see here, the stone appear as a hyperdense structure with posterior acoustic shadow, but in this case the stone lies in the lower calyx with no obstruction of the pelvic cell system. If we compare it with here, the stone lies in the renal pelvis with back shadow, and the dilatation of the pelvic cell system can be seen here with the presence of dark black color, which represents the urine in the dilated pelvic cell system. Previously used the X-ray, which is the kidney, ureter, and bladder, which was used for diagnosis of stones, but it has a disadvantage due to the gaseous distinction of the patient, on some stones are radiolucent, which cannot be easily seen. Nowadays, it's replaced by the spiral multi-slice CT, which is the best diagnostic modality for diagnosis of stones. In addition to urine analysis for detection of hematuria, pyuria, highly acidic urine, which pH value less than 5.5 predisposed for uric acid stone formation, or pH value more than 7.5 indicating infection, which predispose for formation of sulfide stones, and also culture sensitivity in case of detection of uh, susceptible microorganisms for treatment of infection. kidney function tests such as serum urea and creatinine, electrolytes such as calcium, phosphorus, uric acid, magnesium level, and serum parathyroid hormone may also be evaluated. This agile algorithm which is used for treatment of the stones depending upon its size, depending upon its location, and the modalities which are available for stone treatment. If we start with the renal or pelvic axial stones, if the stone is less than 1 centimeter, is well or retrograde renal surgery is the first option for treatment of stones, or sometimes people do percutaneous nephrolithiasis, especially in lower calcium stones, where the drainage of stone is very difficult after as well, or accessibility using flexible endoscopy is also very difficult. In case of stones more than 2 centimeters, percutaneous nephrolithiasis is the first option for treatment for insurance of a stone clearance. Also, retrograde intrarenal surgery or as well can be tried with the possibility of multiple incision. In case of stones between 1 to 2 centimeters, is either as well or in the urology depending upon the surgeon experience and the equipments which are available at the center. In case of the proximal ureter or the upper ureter, if the stone is less than 1 centimeter, it will come as the first choice or ureteroscopy depending upon the surgeon preference. If the stone is more than 1 centimeter, ureteroscopy is the first option of treatment, as well with the possibility of more than one session. In case of distal ureter, if the stone is less than 1 centimeter, some people may do as well or ureteroscopy, but to our experience, ureteroscopy is better in distal or lower ureteric stones. If stone is more than 1 centimeter, ureteroscopy is the first option of treatment. If the stone is impacted, like here in the brother neck, the patient is presented with acute retention, which is a urological emergency, and he must be operated at the same time with endoscopic treatment or open surgery, depending upon the size of the stone or if it's associated with other pathology. There are different modalities regarding treatment of stones. If we start with the expectant treatment or the conservative management, it's indicated for small-sized stone. We are hoping for spontaneous expulsion of either renal or ureteric stones. They can be done in a single stone less than 5 mm, unilateral with normal contralateral kidney, in a compliant patient with normal renal function. The contraindication if the patient has only one kidney or solitary kidney. In case of distal obstruction, so the stone will be impacted with another cause of obstruction, or in case of active urinary tract infection. Treatment includes high oral fluid intake, non-steroidal anti-inflammatory, antispasmodic, or chemolysis of stone by changing the pH value of the urine by alkalization of urine in case of uric acid stones. One of the non-invasive modalities for stone treatment is the extracorporeal shockwave lithotripsy. The indication for this modality of treatment includes either single or multiple stones with stone burden less than 2 cm in a compliant patient with normal renal function in absence of distal obstruction. Bilateral renal stones or stones in a solitary kidney necessitate a ureteric stenting before as well to avoid obstructive anuria in case of stone impaction. It's an invasive modality for disintegration of either ureteric or renal stones depending upon its size. It can be done safely without anesthesia except in young children. The stone fragments are left for spontaneous expulsion, and the patient is maintained on medical treatment and follow-up to ensure stone clearance and detect any complication if it happens. This is the apparatus which is used in the extracorporeal shockwave lithotripsy. The patient lies in supine position and then the stone is localized using either ultrasound or the normal fluoroscopy, depending upon whether the stone is radio-opaque or radiolucent. It can be used for both types of stone, renal stones or ureteric stones. After the stone is fragmented under the effect of shock waves, they pass distally until they are smaller enough to be spontaneously expelled outside the body. The contraindication is active urinary tract infection or infected stone which may result in septicemia, obstruction of the distal part of the ureter, bleeding disorders unless corrected, pregnancy due to hazard of exposure to radiation, and also due to acoustic trauma which may happen to the baby, aortic or renal aneurysm which may cause rupture and result in horrible bleeding. Complication of the as well, persistent renal colic due to passing of fluids and infection in the distal part of the ureter, ureteric obstruction by the stone fragment forming what's known as Steinstrassen, acute pain in flights due to infection or infected stones, hematuria, or intrarenal or perinephric hematoma, especially in case of bleeding disorders when they are uncorrected. The other invasive maneuvers for treatment of stones includes either endoscopic treatment or open or laparoscopic surgical treatment. The endoscopic treatment includes stone disintegration, which is known as lithotripsy, and/or extraction using an appropriate endoscopy under anesthesia. It may be either retrograde or antegrade. Retrograde using the endoscopy, which is introduced through the external urethral meatus, giving access to the whole urinary tract, or antegrade through percutaneous access, which can be used to approach the renal or bladder stones. The open or laparoscopic surgical treatment, which is limited to specific situations such as stones which are not suitable for isval disintegration, or endoscopic treatment such as huge stone, associated pathology requiring surgery such as uretropelvic junction obstruction or huge prostate with secondary stones in case of bladder stones, failure of endoscopic access to the stone, complication of endoscopic treatment which necessitate conversion to surgery such as ureteric perforation during ureteroscopy or massive bleeding during endoscopic renal surgery. The modality for treatment of renal stones, which is known as the percutaneous nephrolithotripsy, it's indicated for renal stones greater than 2 cm or after failure of Iswell. The percutaneous access is done to the stone, obtained in either prone or supine position under fluoroscopic or ultrasonic guidance. Then this tract is dilated to accommodate the instrument which is used for this type of surgery, and it is known as nephroscope. And then the stone is disintegrated and extraction is carried out. As we see here, this is a tube after establishment of our tract, and the surgeon looks with his eye or using a camera for disintegration of the stone, and then the fragmented particles are extracted or come spontaneously through this tube, and post-operatively we insert a nephrostomy tube for 1 or 2 days, depending upon the color of urine, whether the patient has hematuria or not. Another modality for treatment of stones is retrograde endoscopic stone disintegration using either rigid or flexible endoscopy for treatment of ureteric stones or renal stones in patients in which the PCNL is contraindicated due to bleeding tendency or stones in ectopic pelvic kidney. Here is the first step for performing an endoscopic surgery by passing a guide wire followed by dilatation of the ureter until it is wide enough to accommodate the ureteroscope, and then it's followed by the disintegration of the stone. Here we see the guide wire in the green color, and here is the laser fiber, which is one of the modalities of the stone fragmentation. And after the stone is completely fragmented, it can be extracted either using a Dormia basket or forceps until the ureter is completely cleared from the stone. And this is the flexible endoscopy, which is used for treatment of either ureteric stones or renal stone, especially lower calcareous stones. The large option for treatment of stones is open surgery, which is rarely used nowadays, or laparoscopic surgery in high equipment centers. The open surgery can be used for extraction of renal stones through either pelvic incision, which is known as pyelolithotomy, or parenchymal incision, which is known as nephrolithotomy. Sometimes pyelonephrolithotomy can be done for multiple or branching stones. With irreversible renal damage or hydrochalicosis, a polar, which is partial, or simple total nephrectomy can be done if the kidney is completely non-functioning. Here is a patient during open surgery. The patient lies in his side, which is known as the lateral flank position, and after opening and exposure of the all anatomical covering of the kidney, here in order to extract any stone, which is known as a nephrolithotomy, we make an incision in the renal parenchyma. This is an old technique which was used in stacking stone, which is known as anatrophic nephrolithotomy, which is rarely used nowadays due to the high advances in the endoscopic treatment modalities. Our aim is not only stone treatment, but also to prevent the recurrence of stone, and the patient must be aware of this important point to avoid impairment of the renal function in the future, which may end in nephrectomy. The patient must be informed for drinking a lot of fluids all over the day to ensure a urine outcome about 2 or 3 liters per day. Also, we have to encourage a diet which is low in sugar, animal proteins, and refined carbohydrates, which may cause hypercalciuria and urolithiasis. Animal proteins, which increase the excretion of calcium, uric acid, and also oxalate. Increase the consumption of fiber, which inhibits the calcium and oxalate absorption. And also save any stone, which is passed spontaneously for analysis in order to be able or to be aware for identification of the type of stone, and we can also modify the lifestyle or the dietary habits of the patient. Also, for prevention of stone recurrence, periodic follow-up of ultrasound for early detection of any recurring stones is mandatory. Increase the fluid intake to prevent the urine supersaturation with crystallizing material. Dietary modifications such as decreasing chocolate, mango, strawberry intake, which are rich in oxalate crystals. Decrease the protein intake for uric acid and ureate stones. Increase the citrate intake. Proper treatment of urinary tract infection, changing the pH value of urine either by alkalization in case of acidic stones or acidification in case of alkaline stones such as calcium or infection stones. Surgical treatment for underlying cause such as uretropelvic junction obstruction, ureteric stricture or BPH. Hyperparathyroidism should be treated by parathyroidectomy. And thank you for your kind attention.